I'd like to welcome everybody to our final concurrent session for the Equally Well Symposium this year, 2023, and we are hoping to have 4 speakers. At the moment we have 3 speakers in the room, so I'm hoping the second speaker will arrive. Oh,
sorry, yeah, I didn't know.
Lee, would you like to pop over here and get a... we're being live streamed today, so the speakers are all wearing a microphone, and I will try and run to you all if we're doing questions, so that people live streaming can also hear them as well. So we will have 4 speakers, and I'm going to hand over to Laura Edwards first, who's our first speaker, and I'll let you introduce your title.
Thank you. Thanks, everybody. Good morning, and thanks to Equally Well for having me. So as suggested, my name is Laura Edwards. My pronouns are they, them, and I'm an exercise physiologist working in the Justice Health and Forensic Mental Health Network in the Forensic Hospital. I want to acknowledge the traditional owners on the land on which I'm presenting today, the Gadigal people of the Eora Nation, and pay my respects to elders past and present. I also want to acknowledge our lived and living experienced individuals and the carers that work alongside them, and recognise the strength, resilience and capacity of these communities, and welcome anybody here with us in the room today. Finally, I'd like to recognise and express my appreciation for the patient voice that contributed to the story that I'm going to share with you today, and also to my colleague Elise, the dietitian, who is actually over in Europe these days, but was crucial in setting up these services initially. So the presentation will outline the steps taken to produce an implementation plan for the integration of physical activity and nutrition services inside a high secure forensic mental health setting. The focus is on understanding the importance of integrated physical health care and the role of mental health services in that, illustrating the value of the consumer voice in shaping physical health services. I'm going to explore the complexity of integrating these kinds of services in the really unique boundaries of a high secure setting, and provide practical ways to embed new services in any mental health settings. So let me start by sharing with you some feedback from one of the patients that were involved in the project that I think really highlights the impact it can have to include their voice when shaping any service in a mental health setting. I appreciate that we were asked for our opinion, especially in here where everything is usually dictated and controlled. So to be asked in the first place is a privilege, and then for it to be taken and actioned is another level of respect, which you crave in here. I think that's really powerful. Considering the symposium we are attending, and it's day 3, I do not need to remind you of any of the inexcusable statistics around physical health and mental health. But I will tell you that on a local level, the statistics are consistent inside the inpatient setting that I work in, and that what is arguably the most crucial point and in the case for change is that the patients themselves are requesting the services and support for their physical health in these environments. When patients were asked what the Forensic Hospital could do to improve the journey for patients, a key response was a focus on and access to physical health services. They said it's an important part of the mental health journey to be in touch with these services like a physio, dietitian, etc. And they described wanting to be able to access the right supports within a reasonable amount of time. And that's obviously consistent with the state and national guidelines and policies for people living with mental health issues. So let me set the scene. The Forensic Hospital is a 135-bed facility for individuals experiencing mental illness who have been in contact with the criminal justice system. So that's individuals who have committed a crime and the state deems them as having committed that crime but not guilty due to their mental illness or cognitive impairment. The Forensic Hospital provides care to adults, men, women and adolescents. The dietitian and exercise physiologist were employed permanently in the Forensic Hospital in just 2020. Prior to our employment, any interventions targeting nutrition or physical activity were provided by non-specialist staff, nursing, medical, other members of the allied health team. So the interventions have not routinely involved or targeted consumers' preferences or requirements, or involved consumers in their design or delivery or evaluation. But dietitians and exercise physiologists are really best placed to champion the cause of chronic disease and both in prevention and treatment and management through evidence-based, patient-centered care. We have an understanding of the symptoms of mental illness, evidence-based strategies to overcome the really unique barriers that this population group faces, and unique especially in this environment, and a focus on sustainable behaviour change. And it's not asking more of those who are already overworked and under-resourced to then also provide this service that they don't necessarily feel comfortable providing. In the general population, there are barriers to implementing and engaging in healthy lifestyle interventions, such as confidence and knowledge and time constraints for everybody. In the mental health population, there are significantly greater barriers to engaging in the healthy behaviours, such as the side effects of medications, staff attitudes, negative symptoms, social support, stigma, cognitive impairment, therapeutic nihilism. Not an exhaustive list. But in a secure setting, there are really additional and very unique barriers, including restricted access to outdoor space, highly controlled environment, a lack of appropriate clinical supports. And these barriers exist at the patient, staff, and organisational level to implementing the recommended physical activity guidelines in a high secure setting. As clinicians, we arrived on the scene, we're taking all this background information into account, we have our own clinical knowledge, and we're forming ideas about how we can address these gaps. But prior to jumping in and running our services based solely on our knowledge alone, we wanted to then consider and understand what the physical health services mean to the patients themselves and how they want to be receiving them. Our QI set out to engage patients as a significantly actively involved in the development and deliberation and how we deliver and evaluate and improve our services. We acknowledge that this is not co-design. The power imbalance in this environment is high. And so we aren't suggesting that that's what we did, but we certainly tried to engage consumers and patients in the journey and in the process as much as we could. We started out by benchmarking against other mental health services, looking both just generic inpatient settings as well as other forensic settings. We did an analysis of current processes, developed a driver diagram, looking at the problems to be solved and considering some change ideas. So those change ideas were focused around running patient focus groups. So taking an hour to sit down with patients and on each ward unit and hold open discussions, asking questions and prompting creative thinking, so that we could spend time trying to increase our understanding of their past and current offerings, and what's worked well and what hasn't worked so well for patients to date, as well as individual patient consultations. So we conducted a survey in one-on-one settings as well to ensure that we had it was the exact same format as the group forums, but one-on-one, so that individuals who didn't want to engage in a group setting could also participate and provide feedback. We also conducted consultations with frontline staff. We did interviews with senior health professionals and managers, and we utilised staff in services to gain insights from those working on the ground, nursing team members and medical, to get a better perspective of what it's like from their perspective. At the time of our project, there were 128 patients residing in the forensic hospital, and we were able to engage 69% of those patients in either a focus group or a survey, providing really valuable input on their experiences to date and preferences for how they want to receive nutrition and physical activity services. Just to note, of our population group, 15% identifies Aboriginal or Torres Strait Islander. In comparison, as we know that is consistent with the rest of the incarcerated population, where the numbers are much higher for those groups in comparison to the general population, 3 or 4%. The surveys and forums asked patients what physical activity and nutrition programs they currently participate in, as well as how satisfied they are with these programs. So this list here is describing what they have done to date prior to our services being implemented. And it's really useful and important information. We want to build on top of what works, of what they like, and take what they value and go from there. And I think what's so interesting about this is that it really identifies the enablers to engaging in physical activity in the form of good resources. At the Forensic Hospital, we have a small pool, a basketball court, a small gym, a field, a range of things. It's not the equipment is specially designed, those kinds of things. But we have really good resources as an EP, some of the best that I've been lucky enough to work in, which makes sense because individuals are there for a significant period of time and they have no access to anything else. So it makes sense that those resources are there, but what it doesn't provide is an opportunity to use them if you don't know how. And we know this because our patient population is the exact same as in general in mental health, and our numbers and our statistics are the same in terms of their disease risk, despite having access to such wonderful resources at their doorstep. So next, patients were asked to comment on what physical activity and nutrition programs they would like available to them in the future. And we did this both in an open forum discussion, as well as providing options that they could select and say how interested are they in these services. So of note, walking group is the highest. That's actually because at the time when we were running these surveys, there were extra restrictions in place because of COVID, and so they had restricted access to their ability to just walk the grounds and be there, and so that really prompted us to get out there and advocate for that to be returned to them as immediately as possible. But I think that the real priority areas that you can see here is individualised exercise programs, clinician-led groups, and cooking programs where the focus is on nutrition advice. Right now, there is cooking programs available. They are not often, but they're present. But they're run by the OTs, which are excellent, but focus on functional capacity and don't necessarily have a focus on nutrition at this time. So that was the kind of choose your path. And then in the open discussions, what we found was real patient preferences for individual advice and support, variety, qualified and trusted professionals. You can see here that they're saying it matters to know and trust the facilitator. I want the facilitator to be experienced. I want more time with them, once a week, not once a month. And it should meet the needs of everybody who's attending. So to my point from before, and even from Simon's yesterday actually, that just having the resources in the facility isn't enough. You put a gym in a residential building and it doesn't mean that there's engagement from people who don't know how to use a gym. It only provides engagement to those who are already comfortable in that space. And the same is true here, and they're identifying that for themselves. They want specialised support to engage in the resources in a meaningful way, and that's how we can achieve meaningful outcomes. From the staff consultations, we spoke to peer workforce, primary care, allied health, psychiatry, Aboriginal workforce and nursing. And there was generally an appreciation of the EP and dietitian role, wonderful that they exist, but not necessarily an understanding of how to refer or when to refer to those areas. They acknowledged really good work done prior in terms of our metabolic screening process, being up and running, really consistent in core business, but no clear direction on what to do or how to intervene once they've completed that screening. There was a generalised assumption that because there's only the two of us in the service, that probably you'll just do broad sweeping, generalised support, big sports groups, big group-based activities, and that there isn't room for individualised programs or targeted interventions. And that staff in general felt as poorly as the patients did about the food service that they are provided. That in general, better technology and equipment could be useful in improving the patient engagement. So we grouped these into the 4 key themes you see there. And this is how we developed our implementation plan. So once all the staff and patient feedback had been collated, analysed, it was used to develop what you see here, and it was really focused on providing realistic timeframes. So we set goals based on, as you can see, initially quick wins, things focused on the consumer feedback, the phase 2 evidence-based programs, thinking about how we're going to make sure these things are actually going to provide meaningful outcomes, and phase 3 core business. What we want is for it to be consistent always. I'm going to go into more detail about what that looks like, but just as part of that was also developing a program logic so that we could consider detailed outcomes and how we were going to evaluate effectively what we'd put in place. So that implementation plan looks like this. So phase 1 was really the quick wins. So we've made updates to the record timetable to adjust patient access and increase the number of opportunities for clinician-led sessions, running broad spectrum health promotion sessions, updating some of the equipment that we have available, and initiating forensic hospital events. So last year we ran a triathlon over 3 days. It was amazing to witness. And this year we're working on an athletics carnival. And these events, these hospital-wide events, are organised with the patients. So the patients attend a event planning meetings, and we all contribute together to figure out what those events are going to look like and how they're going to run. You know, in terms of phase 2, we're thinking about evidence-based programs. There's 2 of us, there's 135 patients. And so how are we going to engage people effectively and with up-to-date research? And so utilising students and having them assist us in developing and formulating planning group activities, and certainly finding that they have found that to be a really invaluable experience and opportunity to learn in such a unique environment. And then phase 3, which is, I think, a really important part of it, and something we're really into at the moment, is looking at the core business. How can we focus on creating sustainable services that did not just rely on a good clinician, but are actually sound, consistent, they're a part of policy and procedure, they're embedded, and they can't be erased, which I think is really important. So we have a bigger team now. We have a really small selection of speech pathology, physio, and a few other services. We have a new menu project, working on updating that for our patient population group for every single meal. We're developing models of care and adding to policy and procedure. I'll just finish on a story, if that's okay. So this is to highlight what this has meant to our patients. I wanted to share this story. So the patient said, "I like the forums. Being asked gives a sense of ownership over what happens in here, and you feel heard. Physical activity aspects feel more implemented than the nutrition ones, and it feels difficult to get change to nutrition things in here. Something I personally asked for was individual programs, and I've seen such an improvement. Personally, I've never exercised before I came in here. To have someone come alongside me, provide that support, and make the program suit has made all the difference, and to watch myself improve has been really motivating. It's helped my mental and physical well-being. Being in a forensic hospital or mental health facility, my perceptions wouldn't be that there would be a fitness journey. It really helps the overall experience in here to be able to access these services, especially when I'm feeling like things are hard or low. It's something that I'll take into my life outside of here, and if it was all I took away, that'd be great." I'll finish there, because I know we are short on time. Thank you so much.
Thank you, Laura. I think that's really interesting. I mean, I spent a number of years working in a forensic
Is my mic on? Is my mic on? Yeah?
Which one's yours? There we are. Clickers there. Just move that one to move on and go back. Yeah.
Thank you. Thank you for having me. Thank you, everybody. My name is Judith Biarahanga. That's the right way to say it. I'm going to be talking about hepatitis C care for mental health patients, and particularly a pilot study. All right, before I do that, I'd like to acknowledge the traditional owners of the land. Oh, excuse me. The slides are moving here, but they're not moving over there. Yep. You should be able to. Okay. There we go. I would like to acknowledge the traditional custodians of the land on which I live and work, and I pay my respects to elders past, present, and emerging, and I would like to extend that respect to any Aboriginal or Torres Torres Strait Islander colleagues sitting here with us today. All right, I'm going to be talking about the background of hepatitis C in mental health settings, and more particularly a pilot study that happened where I work in the Hunter, New England. So Hep C is an infection of the liver that's caused by hepatitis C virus, and it causes inflammation of the liver. Infection is acquired when the blood of a person, so I'm giving a little background because I have realized this is the first presentation on bloodborne viruses, so I'll just give a small, little information. So infection is acquired when the blood of a person living with the virus enters the bloodstream of another. To date, we do not have a vaccine, and past infection does not provide immunity for future infection, so which means you can continue to be reinfected. So people with mental health illness, like we've had all week, are at a greater risk of hepatitis C virus as well, infection and hospitalization. It affects them 20 times, up to 20 times more than the general population. So Hep C testing and treatment is not offered in our mental health settings, unfortunately. So hepatitis C was first, for mental health settings, was first mentioned in the 5th National Hepatitis C Strategy, which just expired last year. And it was only mentioned, mental health settings were mentioned in other services that could provide support for priority populations. Fortunately, our current strategy highlights the mental health setting as a key priority setting, and this gives us, we can leverage this to provide services for mental health settings and funding, really. All right, so what did we do? We set out to determine the effectiveness of a clinical practice change to initiate improving routine testing of mental health patients for hepatitis C, and then link them into care and provide treatment. We also wanted to establish the prevalence of hepatitis C among mental health patients, and the acceptability of this initiative in the 2 units that we were going to conduct this. So we did a pre-post pilot study that spanned 17 months for 2021 and 2022, and it included mental health staff, viral hepatitis specialists, and mental health patients themselves. Like I said, the first unit was a 20-bed acute mental health inpatient unit within a rural referral hospital. And the other unit is a 22-bed acute mental health inpatient unit located in a hospital in a metropolitan area. So the initiative was about request, review, and refer. So we requested doctors to offer Hep C testing for all patients routinely and to order both tests. So if you haven't been familiar with testing, you need 2 tests for hepatitis. So there's a screening test and then the confirmatory test, which is the PCR. So, but most times we find that clinicians in mental health settings will just do the screening test, and then you'll be required to come back or go to your GP for the confirmatory test. This initiative required us to collect both samples for both tests at the same time. And there was an instruction that said, if antibody positive, proceed to do the second test. So it kind of shortened the time, and then we didn't need to prick the patient again or call them back, have them visit their GP for that. And then review involved review of results with the patient. So this included the nurse referrer. It's a nurse-led model to review results with the patient and then facilitate additional testing, so such as the fibroscan if it was necessary, or other liver function tests or renal function tests in case they needed to start treatment. And then determine appropriate care pathway for this particular patient. And all this was meant to be done in a period under a week. So we were hoping that when your client comes in, so the average admission is 3 to 7 days in mental health. So we were hoping that in 5 days, all this can be done and treatment started if necessary. And then refer meant that would link via the nurse-led remote prescribing model. So we had, because of the complexities of prescribing hepatitis drugs, antiviral medication, DAAs, the mental health settings cannot afford to have this prescription done in hospital because it's used to be about 90,000 for a dose of medication. So the mental health hospital cannot afford to pay for this. However, if you do get an outpatient prescription, then you can have the Close the Gap scheme or PBS rebates, and then it will come down to $38 or 6 point and some cents for Close the Gap. So we use the nurse-led remote prescribing model in the sense that we had the viral hepatitis specialist nurse practitioner from the John Hunter, so this is the referral hospital, prescribe remotely, and then the client's carer or the nurse, if they were able to, would go to a community pharmacist and get their medication. So the nurse practitioner faxed the prescription to the pharmacy, and then a carer would pick that medication, and then the patient would start while still in hospital. Or if they preferred, if they had a consistent GP that they wanted to keep using, we would then refer them to their GP. But we really encouraged starting treatment where possible. And so determining the appropriate care pathway was really key for this initiative. Okay, so we used a series of implementation strategies, like you can see there. We had great support from the steering committee group, and this is composed of all the leaders of the different mental health settings mostly, and population health. We had access to funding from New South Wales Health for the nurse referrer. And then we had, to build coalition, we had a series of meetings. So we had weekly meetings, we had monthly meetings, we had fortnightly meetings with different groups, just so that we have coalition and to ensure that the initiative is understood and appreciated and maintained at all levels. We did do lots of training with the doctors particularly and the nurses that were in these wards. Then we had developed systems for the nurse referrer to monitor testing, the admissions and feedback to the clinicians and say, this week we are at 35%, maybe last week we've improved by 7%. How are we going? Just to motivate, for the nurse referrer to monitor as well as motivate clinicians on how they're going. We had a lot of resources. We used posters, badges, prompt cards, and we also fed back with lab reports on the hepatitis testing that had happened to encourage, performance feedback. How did we collect data? We used medical records for both testing and treatment, for both participant characteristics, testing and treatment. And then we did a survey and focus group discussions for staff, acceptability, barriers, and enablers. And we did a facilitated survey on mental health in patients. So this was assisted because if you remember, I said these were acute settings, so we needed to have our patient stabilized first and given the green light to go ahead and conduct this kind, like obtain consent, all these things. So it was a facilitated survey after a green light from the staff, the ward staff. Our patients were ranged from 18 to 85 years, and the median age post-test was 39 and 40 pre-intervention. And then the most common diagnoses were schizophrenia, followed by substance use disorder, suicide ideation, trauma, and stress-related disorder diagnosis. Mind you, this was post-COVID, about that time. But this is not, if you see the differences between the pre and the post period, they're not very different prior to the intervention. So in total, we had 633 patients. We had admitted, and we had a bigger number at 492. And that's because, would like to think because that's when business started coming back to usual in 2022, but in 2021, I mean, we had lockdown and all of this, so we kind of attribute the 141 patients to that period, to that lockdown restrictions. We had 221 tests ordered compared to 48 previously, and then we had 24 reactive antibody tests and had 10 of them detected for chronic hepatitis C, so that was a 5% prevalence in those units combined. Of the 10 patients, 5 initiated treatment on the wards, that was using the nurse-led model, and 3 were referred on. So 1 went to their GP because they preferred their GP, another needed the specialist at the Hunter, and 1 was an interstate client, so preferred to go and start treatment where they had family. We're still following up the 2. Hopefully we can find them because 1, they were homeless and many other factors like you would be familiar with in a mental health setting. All right, so overall we had 11% increase in HCV testing. For Unit A, Unit A is a rural hospital, is a 17% increase, and then Unit B, a metro hospital, had an 8% increase in testing, and 50% HCV treatment was prescribed overall. So because our indicator was a prescription written, so that's why it's 50%. But of the 10, we're almost sure that the other 3 that were referred started treatment, but we can't ascertain that because we don't have, an indicator of the prescription. But we hope that they started treatment. So Unit B had a 75% increase in treatment, which we liked and which was good. And similar, and Unit A had 33%. So, what did the patients say about this initiative? So a total of 12 patients responded to the survey, and 92% strongly agree that they would accept treatment whilst at the unit. 83% strongly agree that hepatitis C testing should be part of routine testing on admission. I mean, this is good to hear. And then 83 were confident and would complete the treatment of 8 to 12 weeks because we asked the question if they would do an 8 to 12-week treatment on top of their normal medication. And then 83% strongly agreed to being comfortable talking to a nurse or any other staff on that ward about hepatitis C. And this is because we would like to attribute this to the training and the awareness of the people on those wards. 67% strongly agree that they can be supported by friends and family to complete treatment and are confident they would know how to get treatment. Would like to increase this. 67 is above average, but it's not the best. What happens with the clinicians? The clinicians, all of them agreed that HCV testing was important and we should include it in routine testing. And 90% indicated that testing and treatment was implementable. And this is what the initiative was about, really. We were meant to do this testing not as an additional test, but as part of routine testing. So when a mental health client comes in, they have other tests going, full blood count, urinalysis. Shouldn't we include hepatitis C on those other tests? Because, they are at high risk. All the risk factors point that they need this kind of screening. This was without barriers, so the clinicians thought that they have a high workload burden, and then they lacked the knowledge to complete the care tasks for hepatitis C. Some of them had perceived low importance of testing for hepatitis C, and then they had low confidence with the prescribing. They also had competing medical priorities. Like you can imagine, it's an acute setting. You have other things to deal with in that moment until the patient is stable. And then also the associated requirements are challenging. So to prescribe Hep C treatment, you need to either make a phone call or there's so many steps and a lot of paperwork that you have to do so that you can get that prescription. Well, one is to make sure that we're using the money well, but also we need to probably reduce the red tape because the drug is expensive. We did have facilitators, so clinicians' personal value for Hep C testing and believing it's important was a good facilitator. The reminders and prompts by the program champion, organizing care was good. Like if you had a nurse referrer doing all the paperwork was helpful for the clinicians. The education, and then performing the Hep C along other routine blood tests so that there's no need for extra, consent and all this, and pricking, and then clear instructions, having exactly tell the clinicians, right order, HCV requested, or we would say RNA test if Hep C positive. So it was clear they knew what to do and they knew the right test, because there's a series of tests, hepatitis tests, in pathology when you're requesting. So in conclusion, routine Hep C care in mental health is feasible, and we think implementation support we found that implementation support increased the testing and treatment in our units, and then data on the barriers and facilitators to HCV care will be used to refine our implementation strategies to better support mental health clinicians, and these strategies, we need to test them further. So essentially, if mental health, New South Wales Mental Health and the Health Commission, I'm essentially saying, please help us do robust research so that we can know whether or not these strategies are good for, on a large scale, so we can inform local, state, and national policy as well as practice. So these are the posters we used. And I would like to acknowledge Hunt New England, Mental Health, New South Wales Health, John Hunter Clinic, the Mental Health Lived Experience Advisory Group, and the Aboriginal Mental Health Service and Workforce Group. There's a whole team behind me that did this work. Some of them are here in the room, Marie and Caitlin. There's people at home, probably they're watching, and I'd like to say thank you so much for the great work.
Thank you, Judith. Really interesting presentation. Does anyone have any questions? And the rest of your team at the back table, are they?
Yeah.
Okay. Does anyone have any questions for Judith and her team?
Sorry. Thank you. Fantastic presentation and work. I was just wondering around when this started, because I've seen mental health units do hepatitis C testing, trying to do it on their own, and I've seen like yours try and do it on their own and get into mental health. But how did that start with that connection? And what was it like interfacing with the mental health service? Because that can be quite tricky from the two different frames of mind that you come from.
Yeah, thanks for that question, Patrick. Yes, so we did have a long-standing relationship with mental health. So it started off with the HIV AIDS time when we're trying to introduce routine testing for HIV in mental health settings. So we've had a long-standing relationship. So we leveraged that and moved on to hepatitis C when we needed to. We did conduct a lot of meetings. We met with literally everybody in those units. Unfortunately, when we were ready to start the project, Unit B, where we saw the 75% increase and just the 17%, was a new unit altogether. We had never interacted with it. So the original unit was changed because it was made into a COVID ward. And so we had to move into another mental health acute setting. So we're actually excited that we saw those results because we had no relationship with this unit. We had spent almost 2 years trying to build a relationship with the previous unit, only for it to be closed down for, a ward. But the essential, to answer your question, is that you have to meet with everybody. We met with the consumer group, and they advised us on this model, so we didn't just wake up and just think. We had meetings with the clinicians, the doctors, the nurses, the steering committee group. We had a lot of work happening 2 years prior, engaging 2 years prior to starting the project. Yeah.
Thanks. Is it quick? One quick question.
So this is just to add to Judith's input, because I was one of the nurse referrers that was originally trained, and I know initially when this project was, before it actually started, there was a lot of in services that Megan and Judith were involved in talking about Hep C and how we actually felt about integrating it into our care. And, you know, I work in the mental health and substance use outpatient service, but I have worked in the inpatient unit, which we were originally considering starting with. And I know, you know, those conversations actually piqued my interest, as it did a lot of clinicians within my service. And I think that's kind of where it started. So we already had this relationship that kind of just continued from there.
Yeah. So building relationships really is the key thing. Yeah.
Thank you, Judith. And I'm sure you'll be happy to talk to people afterwards if they've got further questions.
So thank you, everyone.
Thank you. Going to welcome our third speaker, Lee Clammett.
Thank you.
Change it did. Yep,
It did.
there you go.
Oh, fantastic.
15, just for 2 more minutes.
Perfect. I go right for...
Yes, that one moved you on.
Okay,
Goes
perfect.
back.
Oh, fantastic. Hi, everyone. Now, looking at all the other speakers before me, it felt like no one of them were nervous, so I'm quite nervous. I would like to start off by acknowledging the ancestors, elders, and families of the traditional landowners of the land that we're standing on today, but also the land where I'm conducting my research, which is the Kulin Nation in Melbourne. And I will be talking a little bit about the integration of physical activity into young people's substance use treatment and the aspect of shared intervention design. My co-authors, unfortunately, are not here today, so it's my role to take over the presentation. I'll talk a little bit at first about problematic substance use in young people and physical activity. I will then give a little bit of an overview over my own research, which has 3 phases. The first one looks at the research evidence. The second phase looks at young people's expertise, and phase 3 is currently in progress, which is developing recommendations based on the research. And I will then talk a little bit about outcomes, conclusions, and key suggestions for research and practice. And if you come across the words PA or SU on my slides, they mean physical activity or substance use. So about my background, to explain why I'm doing the kind of research that I'm doing, I trained as a clinical psychologist in Europe and did my master's placement at St. Vincent's Private Hospital here in Sydney. And I then went on to work with young people who are dealing with problematic substance use in Germany, and then switched to conducting my PhD on young people with problematic substance use and physical activity in Melbourne. So when we talk about problematic substance use, what are we talking about? So the definition of problematic substance use is substance use that causes health, social, legal, or other issues for young people. And problematic substance use, especially in this population, can lead to impairments in key life areas, which then can lead to poor social and health outcomes throughout the life course. Problematic substance use generally affects 1 in 6 young Australians, which is quite a lot if you think about it, and usually comes comorbid with mental illness, high-risk behavior, and suicidality. And we now know that while the initiation phase of substance use is usually during adolescence, the peak age of problematic substance use is actually during young adulthood and early adulthood, and the most affected population is young people aged 15 to 25. Yeah, problematic substance use usually peaks before the age of 27 overall. So physical activity intervention. There is generally natural decline of physical activity during adolescence, which can be reinforced additionally by substance use. So it declines even more basically. And research evidence has already shown that there may be a beneficial effect of physical activity interventions for substance use reduction, both in adults but also in this population. And we talk about when we talk about physical activity intervention in setting, we talk about all kinds of approaches that lead to increases of physical activity among a certain population. And it's important to acknowledge that these approaches are not just behavioral approaches, but they can also be cognitive approaches, informational approaches, societal approaches, environmental approaches, and policy approaches. For example, an informational approach could be physical activity messages or physical activity promotion via, for example, posters or something like that, or yeah. So since I trained in Europe, but then did my placement in Australia, I kind of like, I was in a very beneficial position of like being able to compare specifically, for example, Australia and Germany when it comes to both physical activity in young people with problematic substance use, but also generally their approaches to substance use in young people. And what I've noticed is that there are quite a lot of differences. For example, Australia follows more of a harm reduction approach in young people with problematic substance use, and Germany follows more of a zero tolerance approach, so aiming to get them to not use any substances at all. Australia focuses more on voluntary admission. Germany, unfortunately, I very much agree with that, focuses very much on involuntary admission, hospitalization. And Australia focuses more on a health-driven approach versus Germany, for example, focuses more on a criminal justice-driven approach in this population. But what I've noticed is that one of the things that those two countries had in common was that there's predominantly no integration of preference-driven physical activity in routine care for young people with problematic substance use within the public health sector. Obviously, you know, there may be private health establishments where this is possible, but within the public health sector, it's predominantly not happening. And what I was wondering is there's guidelines and recommendations for a variety of non-communicable diseases when it comes to physical activity and physical activity engagement, but for some reason not for substance use, specifically not really for young people involved with problematic substance use. So the right to health is not granted to many people who use drugs, which was the response of the International Society of Substance Use Professionals to this year's World Drug Report. And my argument is that we should go beyond that because it's not just the right to health, but it's also the right to physical health and inclusion that is not equally applied to many people who use drugs, especially young people. And as I mentioned, there's guidelines and recommendations for so many non-communicable diseases, but not for substance use, and particularly not for young people involved with problematic substance use. So based on that, basically, my research looks at the integration of targeted physical activity into young people's substance use treatment. And I was particularly interested in the research evidence, but also young people's insights. So the research had three phases. In phase one, I looked at the existing research evidence. In phase two, I consulted with young people, both quantitatively and qualitatively. And phase three is developing recommendations for clinical practice based on these insights. So looking at the research evidence, I conducted a systematic review and included any physical activity intervention for the age group 12 to 25 years. Any physical activity intervention that also measured substance use outcomes, and I also explored physical activity outcomes and mental health outcomes. And as additional data, I looked at behavior change techniques that were used in these physical activity interventions, and any kind of implementation data, information on how they implemented it, for example. And I identified 28 international studies of various intervention formats. Some of them were more short-term interventions, some more long-term, but there was a definite beneficial effect of physical activity interventions on substance use reduction in this age group. And I also noticed that there was a significant underreporting of implementation characteristics as part of these studies. And these implementation characteristics, for example, implementation barriers, but also facilitators basically, are actually really crucial to be able to translate and implement effective interventions into practice. In phase two, I started off by conducting quantitative surveys with young people. I should mention this was already, this was still in the phase where it was quite uncertain where, if we were going back into a lockdown or not. So everything had to happen online, basically, because of that risk. I recruited young people via online social networks, community groups, and student services. And young people were eligible if they were aged 16 to 25 years, based on the concept of mature minor, if they were involved with problematic substance use, which I defined as a moderate or severe risk of experiencing health or other problems because of their substance use. And it was a help-seeking population, so they either had needed to have prior engagement with health services, or they needed to express willingness to engage with clinical services in the future, because obviously we wanted to investigate the acceptability of physically active interventions in a population that would potentially actually use these services. So this is just a little bit of an overview of the online questionnaire. I basically did screening for age, substance use, and their willingness to engage with clinical services. And I assessed nicotine dependence, mental health, their current physical activity engagement, and also the treatment acceptability of a physical activity intervention that aims to reduce substance use. And I also assessed exercise benefits and barriers that these young people were experiencing. And the outcomes showed that young people found physical activity-based interventions very acceptable as part of substance use treatment practice. They found it very appropriate and also perceived it as effective for helping them reduce their substance use. And I had an immense amount of 94.9% of young people who also expressed a willingness to engage in these kinds of interventions as part of the substance use treatment. And I should note at this point, obviously, there's a certain selection bias because participants self-selected into the study, which we need to acknowledge when we look at the incredible acceptability of these interventions. A little bit about my participant characteristics. So 77% were at moderate risk of experiencing health or other issues because of their substance use, which would often be called substance abuse, and 23% of young people were at severe risk, which falls more into the area of substance dependence. Most of them were female, 72% were female, 22% were male, and 6% identified as other. And the results also showed that there was a significant negative relationship between the experienced barriers, treatment acceptability, and physical activity engagement. So the more barriers to physical activity engagement young people experienced, the less they found this kind of treatment acceptable, and the less actual physical activity engagement they reported. I also found a positive relationship between the amount of benefits they experienced and the physical activity engagement. So the more barriers, the more benefits they experienced, the more their own engagement, and a negative relationship between mental health and physical activity barriers. So the poorer the mental health, the more barriers young people experienced, and the lesser benefits in physical activity engagement young people experienced. Significant barriers that were named in this research were that physical activity obviously involves a lot of time, it's hard work, and it's particularly problematic if there's no family or partner encouragement when it comes to it. But young people also acknowledge that it improves mental health and mood, and it gives them a sense of accomplishment and control. I then conducted a focus group with young people aged 18 to 25. They also reported problematic substance use, and the focus group was 2 hours long. And we followed a campfire approach, so very laid back, very welcoming kind of atmosphere where everyone could say what they wanted to say. And we also did some online brainstorming as part of the focus group, and it was analyzed via a qualitative content analysis. So just a few example questions that were asked in the focus group. For example, how could an ideal physical activity treatment or program offered by a health service look like for you to want to participate in it? And another example question was, how would the treatment offer feel to you if your experienced barriers are overcome? Would it make it more likely for you to engage in the treatment offer? This is how the brainstorming, like an example for the brainstorming. So young people were basically given prompts and were then able to use online Post-it notes to basically just like give their thoughts to those prompts. And this is the overall outcome of the focus group, and I will talk in more detail about this. This is just, I felt, a very beautiful graphic. So the results showed that young people clearly favored highly tailored interventions. They expressed needed supervision according to the treatment stage. So early on in the treatment, they favored supervised physical activity. Later on, they felt that they didn't need that anymore. They favored clear directions when it comes to physical activity. Interventions that are led by passionate clinicians who are motivated about physical activity. And they also really pointed out the need for social connection as part of physical activity interventions and informative education. So actually learning about the positive effects of physical activity for substance use reduction. They also identified clear barriers, for example, around substance use, social barriers, but also the lack of knowledge on how to use physical activity to help them better manage their substance use. And other barriers they identified were vague recommendations. So, for example, visiting a health service and a GP saying, oh, just do more physical activity, but not really giving any more advice or directions beyond that, and sometimes inappropriate treatment models that are being offered by health services. So the conclusion is that physical activity may be beneficial for reducing substance use in young people or helping them manage their substance use, and it's perceived as highly acceptable and appropriate by young people. They are able to voice clear preferences like highly tailored interventions, passionate facilitators, clear directions, but there's also a lot of service needs that would still need to be addressed. For example, the fact that young people feel that they would need organizational support, they would need additional engagement aids when it comes to physical activity interventions, they would need decision aids. And one of the things that kind of stood out was that they also pointed out that they really need continuous progress checking, and I guess this is also related to this particular population of young people who are involved with problematic substance use. So they actually favor having a treatment team continuously checking on their physical activity progress and making sure that they're on track. So key suggestions are obviously much more research is really, really needed. The important thing is if we are to develop these kinds of interventions, we really need to include young people as partners and key stakeholders. And it was mentioned in one of the presentations before that co-design is just really crucial in this area. So co-designing policy and interventions and also conducting more focus groups. Is really important that, especially in this population, we are having non-stigmatizing open conversations and we're following a health-driven approach because, after all, problematic substance use is not just a criminal justice matter, it is a health matter. And young people do have the same right to physical health as anyone else, basically. And really need to focus on increasing access and reducing barriers. So, for example, actually establishing additional collaborations between schools, universities, and health services. And I just want to point out at this point that when I talk about these potential physical activity interventions that we could implement, a lot of people often think about like comprehensive, large-scale interventions that need a lot of funding, obviously, that we often don't have in the public health sector. But a lot of the preferences that young people expressed, basically, for example, clear directions, or more information on how physical activity could be used for helping them manage their substance use. A lot of these things could be readily implemented in existing services without actually needing any additional funds if clinicians just kind of like took the extra 5 minutes to address these things. Yeah, thank you very much for listening.
Thank you, Lee. I think there's lots of common themes around the ability to build in low-cost interventions into processes from Simon, Law, and yourself that are coming through. Does anyone have any questions for Lee? Patrick?
Wait, no one asked any questions. Sorry. I noticed in your characteristics that 77% identified as female, which is quite different from what I've seen in substance use services that I've worked in before. And I was just wondering if you know any, explore why that is.
Not quite, but I mean, often, well, there is this kind of assumption that females are often like more likely to just kind of engage in research, which I'm guessing was probably the case in my case as well.
great presentation as well.
Thank you.
Any other questions for Lee? Thank you, Lee.
Thank you.
Wonderful. I'd like to welcome Alfred Wong next for our last speaker for this session. Sorry?
Am I supposed to do something? Oh, it's on.
No, it's on,
good.
I think.
Excellent.
You're wired.
Okay.
Just check. Should I do... Yep. There we go.
Okay.
It's okay, just take as much time as you like.
Okay. Forward. Okay. First of all, I would like to acknowledge the traditional owners of the land on which we meet today and pay respect to elders, both past and present. As you all heard today, the presentation was on surveys and policy implementations and programs. And today, what I've got here as the last presentation, hopefully will add another dimension to this big project and this mission that we're all undertaking, that is to help people suffering from mental health. This particular project is really a project that is of national significance in a sense, because what we aim to do is to replicate a national study, and that involves a range of data sets. And because of the type of data that we actually collect comes from different agencies. As you're probably aware, PBS, MBS is actually owned by, or the data custodian of PBS and MBS, in fact, from the Ministry of Health, whereas the data from the census, for example, is actually managed by the ABS. To be able to put the data together, it's a challenging task. It's a very long process, and what we can get out of that is that we can have age groups, we can have demographics group, and we can look at the death rates. At the end of the day, we can also look at the, how these death rates or mortality rates actually changes over time. And, I'm sorry, I'm jumping around with the slides here. The main part of this analysis is to actually try to replicate what was previously done in 2011. The data was actually published by ABS in 2017, and we want to actually try to do the same thing to see whether there's any changes in terms of MBS, PBS, mortality rates, and so forth since the last survey. And for us to do that, literally we have to go into PBS and MBS data sets, and these are real data that you and I, see doctor, we get some sort of subsidies, you get back some money out of pocket and you have to pay out of pocket and so forth. So these are actually data, day-to-day data that you and I at the individual level actually will actually provide to MBS as well as PBS. So you can imagine the volume, the sheer volume of data we have collected. So just give you a bit of a perspective, just 1 month worth of data, for example, PBS, has around about 10 million observations. Okay, so let's give you a bit of a sort of perspective as to what sort of volume of data that it's involved here. And we actually used 2016, the whole year worth of data, PBS as well as MBS. So you're looking at hundreds and millions of observations, not just a few hundred thousands, okay? And so what do I get out of this? Well, at the end of the day, you get something like this. I'm just jumping a little bit here. We get this. So you look at columns like this, you look at it, a few thousand observations and stuff like that. But in order for us to get there, we have to actually start from scratch at a very individual level and code them and link them and so forth. And so what did I found? Well, at the end of the day, there is an increasing trend of particularly female use of MBS, particularly by female relative to male. This is for 2016. And for PBS, we're seeing similar trend. This is for 2016. And the use of both MBS and PBS, again, it's actually a higher proportion for a female across the different age group. Now, in terms of comparison, so what I've done here is to look at 2011 and 2016, how much MBS and PBS use has actually changed. What we can see here, CAGR, is actually the compound annual growth rate. So in other words, purely by looking at the rate of change or growth rate over that 5-year period. So you're looking at 13% increase in usage of MBS as well as PBS. Now, this is just a bit of a perspective in terms of how we actually link, and once we link, what we can see is that out of death records, so for example, in 2011, there are around about 150 people died, right? And in 2016, we have around about 180,000 people died. Out of that, we can actually break it down to PBS proportion, MBS, and as well as joint. In other words, use both MBS and PBS. And we also can actually categorize them by saying, there are people who actually don't use any of these type of treatments or services, okay? And by the way, these are all mental health related cases, okay? So of note there, I guess, if you do a comparison of 2011 and 2016, we can see that this figure here, 77593, this is actually a non-user, this is a proportion of non-user of MBS and PBS system. And that proportion has come down to 46%. So in other words, more people are using the system or the services, MBS, as well as the medication treatment provided by PBS. A very quick comparison in terms of the crude mortality rate, you can see here in the third column. This trend is quite standard and quite similar to 2011. And typically, as the population age, you have a higher rate of mortality, and this is crude. And the standardized mortality rate, in other words, if we were to compare 2016 to 2011, you can see that there is higher in terms of number of times. If you have 1, it indicates that 2011 mortality rates is the same as 2016. So you can see that they are all in excess of 1. That's pretty across the board, particularly for the younger age group. So we can also unpack this further by looking at states and also remoteness area. This is all defined by the ABS. Of interest as well, the very remote region has relatively higher SMR. So the major cities are relatively lower. This is, again, in comparison to 2011. Across the board as well, those are the areas that are considered as disadvantaged using the index of relative socioeconomic disadvantage. The first quartile is the most disadvantaged in terms of low employment, and socioeconomic factors are probably the worst. You can see that the difference between 2011 and 2016 in terms of the mortality rate, it's a lot higher. So some other factors in terms of employment, I think that was mentioned in day one in the same theme, this particular theme B. Employment is also showing up as well. Education, we can see that they are all in excess of 1. So very quickly, we have also the underlying cause of death. So we are able to unpack further by looking at these individuals who suffer from mental health and what are the underlying causes of death. These are all the numbers to do with deaths. So in 2011, we have 75 over 1,000 people who died, and we can group them in terms of underlying cause of death. Okay? And likewise, we do that for 2016. Now, in terms of the proportion of total death, again, we have ischemic heart disease as number one. It's highest in terms of proportion. And that proportion is slightly lower, but overall, you can see that they're still relatively high. SMR relative to 2011 is reasonably high as well, so in excess of 1. So I guess this type of disease or underlying cause of death is still persistent in a sense. So there's some implication in terms of, we need to be a bit watchful of those kinds of disease or comorbidity in terms of people suffering from mental health as well as at the same time going through those medical conditions. So very briefly, there's a few possible or potential implications, and one of which is to say that how do we communicate these mental health conditions, particularly to the female population. And I think this can be a very challenging task in a sense because, guys may not be entirely happy because we need to have equality, and that's what we are talking about here. So how do we communicate that? What is the right channel? Funding support, again, particularly to the more sort of remote regions. As we saw, the standard mortality rate is actually higher for those regions. How do we train and how do we encourage more people to take part in the mental health services? I think this is of national significance since COVID has been identified as one of the most significant shortage in terms of services in the mental health area. I think there should be some sort of incentive or encouragement, both from the government as well from private organization. And funding model and as well as, sufferer going through some pre-existing conditions at the same time suffering from mental health related issues. Okay, these are very early results. I would very much appreciate not to quote any of this because we just got the last clearance from the ABS last Friday.
What's the mental health done?
Okay. Yeah, so this is very, very much straight from the oven. So, but nonetheless, I think it's a start. So happy to take any questions.
Thank you, Alfred. It's great to see that we've got some of the data out. I was actually hoping, because I was speaking to Alfred beforehand, I wanted to ask him whether he was happy to just share a little bit about his experience of trying to work with this size of data and what it's like in terms of timeframes to access it and then trying to work with it.
Yeah.
If you could.
Yeah, sure. So if you're not familiar with database system, it will be a bit of a challenge. So what I do is, because the data files are so big, so you're looking at in excess, and when you actually merge 6 or 5 files together, or even 12 altogether, that's humongous. So what you need to do when you get a file like this, you need to actually narrow it down to variable of interest 1 or 2 or 3. One of the things that also of significance in this study is how to link it. So because the PBS and MBS are core items, they have their linkage. So it's a special ID that you can link this individual's data together. But because Census is a different organization managed by ABS, to link these sets of data together, you need to use a spine. And that is a hard lesson for me to learn. It's a separate sort of ID that you need to look at in the folder, in the ABS datasets folder. So what they call the concordance. All right. So that took me quite a while to get there. But anyway, it's been a very fruitful experience.
Yeah, certainly. I was also just going to ask Alfred, just in terms of the time frames you need, or are you going to answer that, to actually get this done?
Having also been involved in this project, I guess a couple of pieces of gratuitous advice is allow 2 or 3 times as much time to get the project started. It's got to go through the data custodians. This is census data on everyone, including you and me. And so, you know, the ABS security is like there's 7 levels of security, etc. But it's got to be all the projects, people have got to be vetted. It's got to be approved by the data custodians because it's linking data from the tax office, from Centrelink, the National Survey of Mental Health, the census, as well as ABS and PBS. So everybody in Australia's data is on that. There are hundreds of millions of data points, but just so you understand the security, if there was any leak in that and breach in that, so take, I'd say 3, maybe 4 times as long as you think, because it's got to go to data custodians, then there'll be a question, it's got to go back to them. The Commonwealth take a while, the committee doesn't meet regularly. Then they'll go, like for our experience, went to COATSIS, which is the Aboriginal and Torres Strait Islander Coalition Advisory Group, sat with them for 2 or 3 months, until eventually they said, oh no, we don't need to look at it. But that's 4 months down the track. So there's 4 months on that one step, which it turned out to be not needed, but that's the processes. I think the other thing that, speaking on your behalf, Alfred, is the data analysis is not on your computer. It's all got to be in the data lab because of the data security. And also for anyone to get in it, you have to do the training. The training's not regular, so the training might only occurs every 3 months. To be a data discussant, to actually get your hands on the data, you have to have special training and pass an exam around all of your data, etc. So that takes another 3 or 4 months. And then finally, like working in the data lab is slow because it's a virtual environment, which it has to be. You can't save anything, you can't take screenshots, it's all got to be in the ABS website, the files, etc. And then the files have to be approved. That's why Alfred just got it Friday. Then the data custodians have to look at the files to make sure that you've met their security guidelines and there's no possible identifying information. They have all these rules, it's fair enough, but just to say, wow, it's complicated, as it should be, but it probably takes, 5, 6 times as long as it will be expected, I think. And we're really just now taking it back to our Data Management Advisory Analytics Committee to then ask, to really, I guess, verify and validate that data. So my message is this is massive, but it's so worthwhile. It's such internationally, all our international colleagues are just so envious of this, that we actually have this multi-agency health integrated data project. Now, as when we heard this, we thought, oh, it's all integrated. Well, it sort of is. There's a spine which you can integrate it, and so that's fantastic. But there's still a lot of work, as Alfred spent weeks just linking across the spine. That would be my reflections from a distance, not actually doing the day-to-day data analysis.
Yeah, just to add to that very quickly. So just to give you a bit of a comfort, because your data is in there as well, right? Whatever we do post-training, when you go into the system, whatever you do is recorded. You have to click on that condition of entry. Otherwise, you can't access it. Everything you do is recorded, so you can be prosecuted if you do the wrong thing. So just let you know.
Thanks, Alfred.
Thank you.
And then once you've done I've just got one last question. When you do you've decided on your final tables and you're actually going to produce something and the report, do you have to go back as well and get their approval for the final step of actually making
from
releasing?
ABS?
Yeah.
ABS, I think.
ABS and PBS?
Yes, no, ABS is actually under the Medip custom project. They are actually the custodian, as far as I understand. So everything they vet through the output clearance team is I understand sufficient for that purpose. Okay. Yep. Yep. Yeah.
20 people on it who all will check it and make sure that there's no inerrant assumption, no wrong assumptions or analysis, but the tables themselves have been cleared by the ABS. But then after that, it has to be cleared and endorsed by our advisory committee, which is all part of your submission to the ABS to even get the project up.
Thanks, Russell. Did anyone else, that we kind of took over, did anyone else have any questions for Alfred? No? Okay. I want to thank all 4 of our speakers. They were all very different, fantastic presentations, showing us little bits of aspects of work that people are doing with vulnerable populations, and all looking to try and improve the physical health and well-being of people experiencing mental illness or mental health challenges, including substance use disorder and other aspects of that. But so thank you very much to everyone. I have one little thing. Some tables have got a little QR code in the middle of the table. It's our survey. It takes 1 minute. We're closing it this afternoon, and you get a chance to enter and get a $100 JB Hi-Fi voucher, and we'd really appreciate your feedback. Anyway, thank you very much, and enjoy the last session.